Good morning, everyone. Welcome to PYA's Unscripted series. Today's topic is Call Coverage Qualms. PYA is happy to present today's webinar on this important topic. Today's webinar is participation-based and uses a polling platform called Slido. To participate in the polls, you can either scan the QR code on the screen with your phone or go to slido.com and enter the event code on this slide into the event code box at slido.com. You may submit questions during the webinar by typing a message into the questions section of the Slido poll. We will attempt to answer as many questions as possible during the webinar. With that, I would like to introduce our presenters, Zach Doolin and Ericka Dickinson.
Thank you. I'm Zach Doolin. I'm a principal at PYA. I've been at PYA since 2008. And a lot of what I've worked on over that time is different physician arrangements, and call coverage is one of my favorite topics. Ericka?
Sure. My name is Ericka Dickinson. I'm a consulting manager with PYA in our compensation valuation, planning, and design service line. I've been with PYA since 2020 and have had the opportunity to partner with Zach on several valuations over the years, but both of us have really kind of honed our focus in on call coverage arrangements, especially over the last couple of months. So excited to continue that conversation today and learn from our participants as well.
As the moderator mentioned, this is participation based. You can go to slido.com or you can scan the QR code. As we go through, we've got several different polling questions. We'll start with an easy one. And each question, we're looking for your feedback, but we'll also share our experiences, what we've seen, what we're seeing most often now, what we're seeing currently. Just try to share a lot of information about call coverage. Hopefully you leave the webinar today with more information than you started with, and we look forward to the questions. Ericka, shall we start?
Let's do it. So I'll get us started with our first question. We tossed you an easy one. So for vacation, do you prefer to go to the beach or to the mountains? And I'll take the opportunity here to share as well that all of your responses are completely anonymous. So while it might not matter as much for this question, as we get into more of our content related questions, please feel free to share openly and honestly. All of your responses are anonymous, both to us as well as the participants. So nothing can be traced back to you or your organization. So it looks like beach is coming in strong, which I have to say I agree with. Zach, what would your answer be here?
See, I like islands. I don't know that I like beaches. I'm not a big sun person, but I like the tropical feel. So I would have to say beach, but it would need to be a island with a beach versus just a regular beach.
I get that, I get that. Also kind of ironic, Zach and I are both located in Knoxville, Tennessee, right by the Smoky Mountains. So I guess maybe we're a little spoiled with the mountains that we wouldn't choose that.
Looks like most are beach people.
Yep. All right, well, it looks like we've got the hang of Slido. So I'll take us into our next question. This one's really just kind of to understand who's in our audience today. So approximately how many physicians does your organization employ? 0 to 50, 50 to 100, 100 to 250, or 250 plus. And again, just wanting to get an understanding, we know that all these different types of organizations face their own unique set of challenges. So wanting to just understand who's in the audience today so we can tailor some of our conversation to things that might be more applicable for you all.
Looks like most are 250 plus. We have some 0 to 50s. I bet the 0 to 50s are non-physician organizations, but I'm excited. This should be fun.
Yeah, a good mix of folks today. Well, Zach, I'll kick it over to you to go through our first content slide, kind of tee us up for what we'll talk about today.
Yeah, I think call coverage from a valuation perspective is one of the most challenging topics to really talk about. Unlike an employment arrangement where you have, a total compensation, then you have benchmarks you can look at, such as productivity, work RVUs, collections, to really understand how productive a physician is relative to those benchmarks. Call coverage doesn't have good burden measures. So it's not like you can point to a survey that has good burden statistics for call coverage and figure out where your physician is performing relative to those and then align that with the compensation. Call coverage, you really have to look at the underlying factors of the arrangement, and every arrangement's different. 3 things you should consider for all call coverage arrangements. 1, the length of call or the availability. So how restrictive or how available does the person need to be? Is this on-site? Is this off-site call? Is this restricted, unrestricted? Is it 24 hours? Is it weekends? Is it night? What is the availability? What's the burden associated with the provision of call? So you're available, but what is the burden? Is it that the physician's called in often? Is it the physician's called in rarely? Is this for trauma? Is this level 1 trauma? Is this level 3 trauma? Is this pediatrics call coverage? Is it NICU call coverage? Really understanding the burden, how often a provider may be called in, the acuity of the patients, and really the difficulty with this call panel, and then the likelihood of receiving payment. So one of the reasons call coverage payments exist is call coverage is for any patients that comes into the emergency department. So what's the likelihood that a patient that comes into the emergency department or is seen for trauma is uninsured and has no insurance, but the physician providing the coverage is still responsible to provide the care, regardless of the patient's ability to pay? So when we look at call coverage, we look at those 3 aspects of it to measure the burden, and then try to, use our best appraisal judgment to say, based on the burden of these 3 criteria, where on a range of benchmarks do we feel like this arrangement may fall from a valuation perspective? And then even sometimes when you may think it's a very high or very low burden, the market still dictates and sometimes where the call arrangement may fall. So there may be a shortage of providers or lack of alternatives that causes the arrangement to still fall closer to the higher end of benchmarks, even though the burden may be at the lower end of what we've seen for other arrangements. So it's just a very challenging topic to discuss and to understand from a valuation perspective and from a fair market value perspective. And as we go through all the different questions today, we'll try to talk about some of these different topics, to hit on some of these key points, and just share what we've seen and talk about some of the intricacies of call coverage as we go. So our next question, of your organization's providers who provide call coverage, what percentage are independent contractors, not employed? My thought here is that it's probably going to be a mixture. I've seen organizations where all of the physicians per call are employed. I've seen organizations where there's no physicians, no one's employed, so it's all independent contractors. And you have a mixture, and that's probably what we'll see. Some of it, a mixture where you have some specialists employed, some specialists that aren't. But just curious, as we were coming up with questions, this is something we were interested to see what most would say.
Yeah, and I also think in consideration, we've got a lot of larger organizations on the call today. And so they might have a larger employed provider pool to pull from for call coverage. So we might see a little bit less independent contractors, which looks like it is coming true in our results.
Yeah, looks like 20%, up to 20% is the number.
Yep. So our next question, does your organization pay employed physicians the same daily call coverage rate as independent contractors? And this kind of conversation around independent contractors and employed providers has really been top of mind for Zach and I as of late. We just recently wrote an article kind of digging into all the differences between independent providers and employed providers and what you might consider when you're considering a per diem rate for each of those types of providers. So interested to see how the results fall out today and if that's similar to what we've kind of been considering as we've thought about this topic.
Yeah, there's really no right or wrong answer. You have to really look at the arrangement itself to understand, is the physician paid for day 1 of call if they're employed, or does the physician have to provide so many uncompensated days of call coverage first? Are the physicians able to bill and collect for services when they're on call? If you balance all of these different pluses and minuses related to the payment and the burden together to determine whether an independent contractor should be paid a different rate than an employed physician, or if the employed physician should be paid at all. Their salary may cover all of their call coverage compensation.
Yep.
Looks like a pretty good mixture.
Yeah, the majority no.
Yeah, I would say most of the arrangements I've seen typically pay the same per diem rate, But when you have an employed physician versus an unemployed or versus an independent contractor, there's some consideration to the employed physician salary. Are your organization's independent contractors allowed to bill and collect and retain professional collections while on call? I would say most of the time, yes. I've seen a few arrangements where that's not the case, but I would say 90% of the arrangements I've seen, if an independent contractor is providing call coverage, they're also able to bill and collect for the professional fees. Do you see anything different, Ericka?
No, I would say that's really consistent with my experience as well, and something that we've thought about. There's risk involved with being allowed to bill and collect for your services rendered. Professional collections are never guaranteed, but it's an expense that those independent contractors will incur whether they collect or not. So again, to Zach's point earlier, it really plays into your payer mix, plays into if you have an external vendor doing your revenue cycle management, their efficiency and effectiveness in collecting as well. So definitely a risk involved for independent contractors being allowed to bill and collect.
And not surprisingly, 83% sometimes are yes. That's consistent with our experience.
Absolutely. So our next question is rank-based. So in what areas does your organization have the most difficulty securing call coverage? 1 being the most difficulty and 3 being the least difficulty between medical specialties, surgical specialties, and hospital-based specialties. So I know what I would expect to see here, but I know that this can also be really dependent on the organization. It can really vary. I know we've got some large organizations in the group, but we don't know where people are located geographically. I see a lot of rural hospitals kind of struggle in maybe different areas than a more urban hospital might. And this might also depend on any certifications that your organization has or any credentials, such as like a level 1 trauma center. You may have some requirements that you have to have some surgical specialties available 24/7. And so that might create a greater need and demand for those types of services as well. And it looks like this is coming out pretty consistent with what I expected to see. So surgical specialties being first, we've got medical and hospital-based kind of competing for that 2nd and 3rd spot, but it looks like medical specialties are going to pull slightly ahead in number 2 and hospital-based specialties in number 3. Zach, does this surprise you at all?
No, and I think we'll talk a little more on the next question about what specialties in particular, but this is exactly how I thought it would fall as well.
Yep.
So this one's a fun one. This one is a word cloud. So you type in the specialty that you think, but what specialties are the most difficult to secure for call coverage? The 4 that I was thinking of before this call, ophthalmology. For some reason, ophthalmology seems to be very difficult to obtain. Urology, ENT, and gastroenterology. Those seem to be the hot specialties I'm seeing right now. Cardiology is a good one. Behavioral health, very hot topic at the moment.
Yes, that's one I see a ton of. I've actually got the Sullivan Cotter survey pulled up, their most recent on-call survey, which is from 2022, and they report the top 4 specialties as OBGYN, orthopedic surgery, plastic surgery, and urology. So kind of consistent, Zach, with what you've said. I know they've got a new call coverage survey coming out later this year, so I'll be interested to see if and how that changes in the new data.
I think with the aging population of baby boomers, urology is one that is becoming more and more prevalent now. It wasn't as popular 10 years ago in my experience. Behavioral health is one of the hottest specialties for not just call coverage, but every type of arrangement at the moment.
Yes.
So very interesting results. OMFS and facial trauma, that's a fun one. We talk about concurrent call coverage later. We'll talk about OMFS and facial trauma. That is a fun specialty to try to value and understand the intricacies of.
Absolutely. For our next question, are the majority of your organization's call coverage panels restricted or unrestricted? I would say probably 90% of the evaluations that I receive from my clients are related to unrestricted call coverage. But I will say that really in the last couple of months in 2024, I've gotten a couple of requests for restricted call coverage. So interested to see if that's reflected here today. But it looks like we're going to have 100% unrestricted.
You know, it's restricted panels are typically trauma panels, your trauma surgeons that are required by trauma standards in some instances to respond immediately or within 15 minutes. So there's really no way to do it in an unrestricted manner. Also, I've seen OBGYN where the OBGYN panels are restricted, typically in hospitals with high birthing rates. It's just there's such a need for an OBGYN on site that it becomes a surgical or a OBGYN sort of hospitalist model, if you will, where the OBGYN is not technically being paid by the hour, but they're in a restricted call coverage situation. But I would absolutely agree with the results. Most everything we see is unrestricted.
Yeah, and Zach, I would echo that as well. I see a lot of OBGYN for restricted. And to your point, you know, if you've got an on-site response requirement of less than 10 or 15 minutes, you know, we might consider that to be restricted regardless, since that time requirement is so short.
That's a good leeway into the next question.
Absolutely.
For your unrestricted call coverage, what is your organization's typical response time to present on site? I would say the most common I see is 30 minutes or less. The next would be 60 minutes or less. And then ones that are 15 minutes or less are almost restricted. So most common, most every arrangement is 30 minutes. Sometimes we see 60.
I'll be surprised if we get any greater than 60-minute responses. That's one I don't see very often.
Yeah, it really begs the question of if someone can respond after an hour, do you really need to have that call panel for emergency department coverage? Or is it something that can be followed up on the inpatient, you know, maybe later the next day? Yeah, so no surprise, 30 minutes or less, 60 following, and then 0 for the others.
So are uncompensated or gratis call coverage shifts included in base compensation for your organization's employed providers? I see this really as a mix and really specialty dependent. So I wouldn't be surprised to see a lot of sometimes for this response. But typically I do see a few call coverage shifts at least included, especially for your hospital-based or surgical specialties. Zach, is that consistent with what you've seen?
Yeah, you know, this is a question. This is a topic that you really have to understand when you're thinking about call coverage, and it creates a lot of confusion with different physicians in the market. If you employ, let's say, orthopedic surgeons, and your orthopedic surgeons are expected to provide call coverage as a part of their employment, there's no additional pay, or maybe there's pay after a certain number of call coverage days. That can be confusing to the physicians because other independent contractor orthopedic surgeons in the market may be paid from call coverage on day one. So sometimes we'll hear that, well, the standard for the market is call coverage on day one, so there's every shift is compensated. And in fact, it's probably true. It's just that in an employed scenario, the physician's receiving that money as a part of their base salary. But that can be confusing when you're trying to recruit specialists to the area or employ specialists. The topic of whether you should pay for the first day of call or whether call coverage included in the base. So it's important to have that conversation on the front end to make sure that everyone understands that, you know, yes, your base compensation includes some provision for call coverage, and here's what our standard is, or no, your base compensation does not include that, but that's why it may be lower than a benchmark that we're looking at versus at another level of a benchmark. So it can create a lot of confusion. And it's one of those items that you really have to understand at the beginning of a call coverage arrangement to make sure that you get it right.
Yeah, and I would add this is a really important consideration when you are looking at total compensation benchmarks. There are likely some gratis call coverage shifts included in that total compensation benchmark. And so we want to make sure that we're considering that, and we are maybe either taking those out or adding those in, and kind of making sure that we're looking at an apples to apples comparison when you're looking at those total compensation benchmarks.
Well, another way to say that, Ericka, is that total compensation benchmarks include total compensation. So compensation from all different areas, medical directorship call coverage, clinical, honoraria, whatever type of compensation, it is included.
Absolutely, yep.
So if you are including call coverage as a part of base compensation or total compensation for a physician package, how many shifts are you requiring the physician to do before perhaps they're paid for additional call coverage? The number I wrote down, let me flip over to my little slide, was 6 to 7 or 1 week. So most often what I see is 6 to 7 days a month or 1 week per month, depending on how the call panels are structured. Have you seen anything different than that, Ericka?
No, that's consistent with what my notes are as well. To speak to the behavioral health that we saw on a previous slide as being a difficult specialty to procure call coverage for, I typically see, I do a lot of psych call coverage evaluations. I typically see about 6 per month to be the average for that specialty, but I'll see a little bit higher for primary care specialties, maybe somewhere around 8 or 9. But again, to your point, Zach, kind of hovering around that 1 week of uncompensated.
Yeah, I've seen 10 days for lower burden specialties, and I've seen 5 days for higher burden specialties. But also depends on how many physicians in your market, how many physicians might you be able to recruit or have on staff. But I'd say 1 week, 6 to 7, 5 to 7 days is pretty typical, which is what the results say.
Seems like it's typical for our participants as well. Our next question, do your organization's bylaws include age-out exemptions for physicians providing call coverage? This is pretty typical, I would say, in the clients that I work with. And I typically see this included in the medical bylaws, so it's applicable to all physicians and not specialty specific. So I'm not surprised to see a lot of yeses here. Zach, is that consistent with what you see?
Yeah, I think I think it is. I would say, if I had to guess, most have some age out provision, but it's not something we, we typically get asked to come in to value the arrangement for the physicians that are working. Sometimes we get into these special situations where a physician is no longer required to provide call coverage. So can you now pay that physician for call coverage on day one? Or if the physician opts out, another tricky question is, should we lower their total compensation package to make up for the work that they're no longer performing? And what a slippery slope, or what a difficult question that is to ask. Anytime you're lowering physician compensation, it's a difficult conversation. And it looks like most of our participants have an age out provision. Not surprising.
Yeah. And a great segue, Zach, into our next question.
Does your organization provide a shift differential for call coverage types? So if someone is on call Monday through Friday, would they receive a different call coverage daily rate versus someone on call on Saturday or Sunday? Or do you break up your call coverage so that nights are paid higher than days, or weekends are paid more than holidays, or how does that work? I would say most of the call coverage arrangements I see have a fixed daily rate that's paid the same regardless of which day of the week it is, except when we get into true shift type work. So any of your hospitalists, your nocturnists, your different types of physicians that may work during the day predominantly versus at night, sometimes we'll see a little difference, but I would say 8 out of 10 call coverage arrangements I see pay the same rate regardless of which day of the week it is. Holiday coverage may be the exception there. Trying to get someone to work that extra shift, there may be a premium for that one day, but typically it's the same rate. I think you could also run into a situation where the group of employed physicians or independent contractor physicians provide the weekday coverage sort of at a discount or possibly even no charge, but to provide the weekend coverage, there's a payment. So there's a premium there or a differential paid, whether it's written down. It could be that the weekdays have no payment, but the weekend there is a payment.
Yeah, this seems to be a hot topic with my clients recently requesting. I think they've had a lot of physicians requesting for different premiums for weekends or holidays or night coverage. Consistent with Zach, I think what I see a lot is the employed providers covering, like we said, maybe you've got 3 in a call panel, and they're providing about a week of uncompensated shifts per month. And so that gives you about a week extra that you need to cover. And I'll see some clients cover that with independent contractors or PRN agreements. And knowing that the majority of those open shifts will fall on weekends or on nights or holidays, they might bake in a premium for that independent contractor rate in consideration that they'll be providing call coverage services mostly on weekends, holidays, or nights.
It would have been a good question Ericka to follow this with if we would have thought about it at the time. But what would the premium be for a night shift versus a weekend versus a day shift, or a weekend versus a weekday? Typically, we see nocturnists compared to the daytime hospitalists earn compensation somewhere between 5 to 20% of the regular daytime physician. Holidays, I've seen as high as 200% of the regular rate. Weekends, my guess would be a 25% premium to a 50% premium, but 50% seems really high for call coverage. So it would be hard for me to truly say that, but I know for sure I'd feel confident that nighttime premiums for shift work would be somewhere between the 5 to 20% premium range.
All right, so back thinking about those burden metrics that we talked about earlier, does your organization track any of the following call coverage burden metrics? So you can answer as many as apply here. We've got a few different ideas on the screen, but also if you respond with other, feel free to drop that in the chat. We would love to kind of see what other people are tracking. But I know from evaluation perspective, kind of the more burden data that we have, the better. Helps to give us a better understanding of what those typical call coverage shifts look like. And especially if we've got the burden data for a longer period of time. We're really trying to get to an average. I know it happens a lot where a hospital operator might reach out to a physician to kind of hear about their averages, and we hear, well, it depends. Some weeks are really crazy and we are in the hospital for our whole call coverage shift. And then other weeks are really quiet where maybe you're answering just a couple of consultations, a couple calls. And so we don't want to provide evaluation that focuses fully on that really busy week or that focuses fully on that really quiet week. So we're looking for an average of your burden when we're trying to do our evaluations.
Yeah, wouldn't it be great if we could get this type of information for every evaluation? Most organizations don't track this level of detail for call coverage. There's not an internal use for it really, other than measuring call burden, and that's not something that a lot of organizations really need to understand. But from an appraiser perspective, it's very helpful for that second item we talked about. We know you're available. We know how much that is. We know the payer mix, so we know sort of if you're likely to get paid when you come in or not. But how burdensome is the call coverage? So these are the types of questions we'd like to know, like to understand. It's often hard to get this data, and as Ericka was saying, one way to get it is to do interview the physicians. Another way might be to do a 2 or 3 week survey, track the data for 2 to 3 weeks, see what comes up. And it is not uncommon at all for us to see a difference in what the hospital thinks the burden is versus what the physician thinks the burden is. So sometimes as the appraiser, it's our job to come in and try to read between the lines a little bit about the two different sets of data that we might receive and measure the burden sort of, what do we truly think the burden of this is, document that in our findings, and then try to come up with what we think a fair range would be in compensation. But maybe one day these metrics will be tracked by everyone.
Wishful thinking from evaluators' perspective. I'm happy to see, though, that our top 2 responses of those who are aware of the metrics that are tracked are the number of calls received per shift and the number of in-person inpatient consultations per shift. I think if I were to cherry pick a couple out of the ones that we've listed, those would be the 2 that would probably be the most insightful for us. So happy to see that those are coming out on top.
This is telemedicine's the next fun topic, and Ericka, I'll be curious as we go through this to get some of your insights, especially related to behavioral health. But how often does your organization utilize telemedicine for call coverage services? I think since telemedicine's been around for a while, but really during COVID and the past 3 or 4 years, we've seen a huge increase in telemedicine. During COVID, one of the biggest challenges was getting that ICU coverage, and we saw a lot of creative different types of ICU telemedicine arrangements. So we've seen more and more, and especially in the behavioral health area. Not to spoil our next slide when we talk about what specialties, but we've certainly seen an increase.
Absolutely. I see this in a lot of rural organizations as well, kind of leaning on the telemedicine call coverage to provide that service. And, there are benefits and challenges related with telemedicine call coverage. Obviously, you can't present on site if you are doing some telemedicine call coverage. So while it's helpful, it has its limitations as well.
Yeah, the never surprises me a little bit. I'm guessing that may be non-physician organizations. I think telestroke is something we've seen very, very beneficial, helps increase response time for stroke. So we've seen a lot of organizations bring on telestroke as a part of any sort of neurology coverage that they have. So
leading into our next question, in which specialties does your organization use telemedicine to assist with call coverage? I think as Zach and I have talked about, definitely expect to see behavioral health here. Wouldn't be surprised to see stroke, to see ICU coverage, some of that critical care coverage as well.
Telepsych's a fun one. And there's a huge benefit to telepsych. There's a lot of rural areas that don't have access to psychology providers that have mental health issues that really need this type of care. There's patients in rural hospitals that are sitting in the emergency department waiting for psychiatric evaluations that telebehavioral health can really help with. Stroke is one that I've seen for many years, even before COVID, when it was just found that you could respond to a patient much more quickly versus driving to the hospital via telehealth for a stroke patient. And time saves brain cells for stroke. So it's really been a really good advance in medicine for stroke. COVID-19, tele-ICU. I've seen that a lot, and how different organizations help to try to meet different leapfrog measures, help to ensure that you have 24-hour coverage, help to have a physician around 24 hours, whether the physician's there or not. Maybe there's a advanced practice provider at night working with the telehealth physician and actual physicians on site during the day. I've seen lots of creative models for ICU with telestroke lately.
Absolutely. Telemedicine and telemedicine call coverage can absolutely be an essential tool for those specialties where time is of the essence, and stroke and psychology are definitely two of those for sure.
One that I'm not seeing on the screen is primary and urgent care. I've seen a lot. My wife's one actually who started when she can, instead of going to the doctor, logging in and doing a virtual visit. Saves a trip to the doctor's office. I suspect that over the next 5 years or so, we'll see more and more doing virtual visits for primary care visits versus what we see now. What types of call coverage payments does your organization utilize? Perhaps the most common is a per diem. We've talked about daily rates several times already throughout the day. Hourly rates, I've seen hourly rates. Typically, I've seen hourly rates when the different providers are only on call for half of the day. So perhaps they're working during the day and then they're on call for night coverage. So that's when I've seen hourly rates. Work RVU payments, absolutely. Work RVU payments are fun. Work RVU payments are challenging sometimes. So it comes back to that question of, does the provider receive payment when they're on call? So an employed physician may not receive collections, but an employed physician may be eligible to receive work RVU payments for that productivity. And we'll talk about that a little more. Activation fees. Gosh, that's a topic that we get asked about a lot. We just don't see a lot of clients utilizing it. So the activation fee is the one where you either pay nothing until a provider comes in, to the emergency department, or you pay a very low rate, and then once the provider's called in, you pay a higher rate. So maybe it's $100 a day to be available, and then if you're actually called in, you get $400 for that day. It's one that we get asked about a lot, but we don't see in practice a lot. But you, Ericka, do you see per diems the most?
I definitely see per diems the most. I am surprised to see 0% for the activation fees, just on how much we get asked about it. And I have seen this in a couple ophthalmology arrangements, particularly where the burden is really low, but if they are called in, it's urgent and they might need to be on site for an extended period of time. So that's really where I see the most activation rates, but definitely per diem rates, hourly rates tend to be the most common, and that's reflected from our participants today. So as Zach mentioned, our next question is about work RVUs. So if your organization's physicians are compensated for productivity, are work RVUs generated while on call included towards their productivity threshold? Zach, what's your experience with this? I would love to hear your thoughts here.
I think I've only seen one instance where work RV productivity via call coverage is not included. And I think that had to do with the tracking of the work RVUs. It was a different sort of different system. But most of the time, if you're employing physicians and you have a work RV payment and that physician generates work RVs via call coverage, those work RVs are included, which is important for you to consider when you're determining what the per diem is or the daily rate is. Are the work RVUs included? When you set the physician's total compensation goals or the productivity goals, did you include all work RVUs that might be generated or just work RVUs from the clinic practice? Does the independent contractor, if they're paid the same daily rate, if they're both paid $500 a day, is the independent contractor allowed to bill and collect? What might those collections look like compared to a work RV bonus?
Yeah.
Not surprising, 63% yes.
Yeah. And again, really agreement specific. There's a lot of different factors to consider when you're considering that, where you're setting your base compensation, where you're setting your threshold, what your comp per work RVU conversion factor is, and making sure that you're considering all of the clinical work that your providers could provide, as well as that call coverage shift. So a lot of competing factors here to consider when you're thinking about the call coverage rates, which makes this such a complicated topic.
So next, we have concurrent call coverage. So we have two slides we wanted to share with you related to concurrent call coverage. I think that's a term that's used broadly. It's certainly a term we use for concurrent call coverage. And what we mean by that is it's either you're providing call coverage for 2 hospitals at once or 2 panels at once within the same organization. So if you're a physician, are you on call for 2 hospitals in the area, or are you on call for 2 different panels in the area? We'll talk about panels on the next slide, but for call coverage hospitals, we a good percentage, not maybe less, maybe 30, 40%. Sometimes we'll see, especially in markets that have multiple hospitals, you have a physician on call at the larger hospital, but the physician's also on call for the smaller hospital. Oftentimes there's some sort of arrangement in place at that hospital within the health system where if the level of care required, you may transfer the patient from hospital B to hospital A. However, we have seen arrangements where the physician could be called into either emergency department, hospital A or hospital B. To structure those types of arrangements, you really have to think about the burden. What's the likelihood of someone being called in? What's the likelihood of being called in at the same hospital or the different hospitals at the same time? What's your backup plan? Is it that you're paying one physician to do this, or are you paying a group of physicians to do this? And that helps you determine the rate. If you're paying a group of physicians and there's a need for both hospitals at the same time, that group is responsible to provide the care at the same time. Whereas if you have one physician, it may be that the physician's already providing or doing a surgery at hospital A, the patient in hospital B may have to be triaged or even transferred. And how do you consider that as a part of the burden? But as we talked about concurrent coverage, we wanted just to give a little more of an example of what we meant by that word, concurrent coverage. And it's really being on call for 2 hospitals or more at the same time. I don't think I've seen more, but hospitals at least at the same time. Anything you'd add there, Ericka?
I absolutely see a lot of the concurrent hospital coverage in behavioral health and psychiatry coverage. That's the one that I get the most requests for. Again, specialties with a high demand for call coverage that are difficult to procure coverage for. That's where we're seeing a lot of that.
Yeah, that's a good point. We also see concurrent specialty coverage. This is something that's very popular in our some of our hospitals that aren't able to recruit as many specialists. So we've seen general surgeons that are also on call for urology, that are on call for all the different types of panels that a general surgeon might be on call for. Even though it's not their primary specialty, but there's still an emergent need in the emergency department for that. Earlier in the presentation, we mentioned OMFS and facial trauma. OMFS, facial trauma, ENT, are two specialists that can be, or three specialties that can really be, I'll throw plastic surgery in there too, and they can really be convoluted. We've seen OMFS physicians that are qualified to do facial trauma, OMFS, and some ENT. We've seen ENT that do both facial trauma and ENT. We've seen plastic surgeons that do facial trauma and plastic surgery. So really looking at all those different panels, you have to understand what panels do you really need, who's really qualified, and how do you pay for it? So if a physician's on call for OMFS, ENT, and facial trauma, how do you determine what to pay that physician? Do you pay them the full rate for all three rates of those panels, or do you have some sort of a discount? And that's really what we wanted to get into on the next few slides, is just a little more information about what you do for these different types of panels. I think it's also important to think about, for hospitals, if it's a trauma center, what do your trauma bylaws require? Your response times. Can somebody truly be available within 15 to 30 minutes if they're on call from multiple places?
Yeah, before we dive into our questions, I think another really important consideration here is making sure that you operationally are thinking through a backup plan. If your physician is called into hospital A and then a call comes in where they would be required to also present to hospital B, that provider can't be in two places at once. Similarly with the specialties, if they're called in for their primary specialty, but then a need arises in their secondary specialty, what's the backup plan there? So if that's, as Zach mentioned, if it's covered by a group, perhaps they have some internal kind of backup call coverage that's going on. I've also seen this where the medical director of the specialty is required to kind of provide that backup call coverage if two are needed to be called in, or also thinking through just a triage plan. When I'm thinking of concurrent specialty coverage, I know one I've seen recently was a general surgeon who also covered GI procedures. And so those general surgery, those asks may need to be a higher priority than an endoscopy or something similar that could maybe be triaged and held until the general surgery was complete. So just thinking through operationally how you ensure that the coverage will be provided on time and in an effective manner.
So with that, how often does your organization's providers provide concurrent call coverage for multiple hospitals within your organization? Not applicable.
I'm interested to see the results here, knowing we've got some bigger organizations in the audience. If there are multiple hospitals included, maybe it's a health system, but we might see a little bit more of this concurrent hospital coverage.
Yeah, we apologize for the typo there. It should be often versus off-turn.
Amazing how many people review these slides and they still sneak in there.
Yes, not a pretty good mixture there. We've got not applicable, we've got never, not surprising, often, and we have sometimes. So it just really makes up. It really has to depend on the system. That's not one that I think is a right or a wrong. It just helps us understand how prevalent sometimes that coverage is.
Absolutely. Our next question is similar. How often do your organization's providers provide concurrent call coverage for multiple specialties within your organization? So specialties being the key word here. Again, no right or wrong, just kind of curious what folks are doing out there. I wouldn't be surprised to see the results pretty similar to the last poll for this question. I would say if you are providing, if your organization, is familiar with providing concurrent specialty coverage or concurrent hospital coverage, those kind of go hand in hand.
Yeah, it's interesting when we're getting information for call burden, especially with that ENT, OMFS, facial trauma, plastic surgery item. If we're interviewing the physicians, what the physicians say that they're covering versus what the other specialist physicians say that they're covering. Every specialty tends to think that they're the most burdensome specialty. And when we talk the different perspectives, it's just fun to listen to the different conversations there. Who actually does what. But results not surprising. Once again, good mixture, just like before.
Yep.
This is one that we are very interested to see what the organizations out there are doing. Especially, this is probably helpful to many of you as well. If you're paying for concurrent call coverage at multiple locations or multiple panels, what amount does the second call panel, or what amount is the second call panel paid? So if your general surgery call is $1,000 and your GI call is $500, do you pay $1,500 or do you pay something less? Most often.
An interesting factor here too, I think, is identifying which call panel is the primary and which call panel is the secondary, and which one of those you take a percent of when you're coming up with your per diem rates.
Yeah, most often we see 50% of the secondary rate. We've seen panels where you get into the third rate and then it's sort of 50%, 50%, so 25%. Most often we see the highest panel being the primary and the secondary panel being the next, so 50% of the lower rate. We have absolutely seen double. We've seen you pay the full rate for both. And there's nothing wrong with that. You just have to go back and look at the burden, make sure that what you're evaluating is consistent with that. And what is fair market value for the combined service? Especially in situations where you have a group. If you have a group of physicians, so you're paying, the health system's making a payment to a group of physicians to provide a certain level of cover. If that group is on the hook to provide two physicians, if two physicians are needed, it would seem to make sense that you pay the full rate for both panels, because it could be that two physicians are needed. So you really have to go back to those three facts, or those three factors, when you value any call coverage arrangement, to understand the availability. Is it one physician or two physicians? The burden, is it very burdensome, not burdensome? And what's the likelihood of payment when you evaluate any call coverage arrangement? That's what's so tricky. There's no, most every question here, I don't think there was a wrong answer. It really varies. And this is one of those frustrating situations when you ask the question and we say it depends. Love to give you an answer, but it really does just depend on all those facts. But you can't always point back to those three facts at the beginning of this presentation, those three factors to consider. And considering those three factors will help you evaluate any call coverage arrangement.
Absolutely. Not surprised by our responses here, but interesting to note, I know Zach and I's experience is definitely, we see about 50% of that second rate. The benchmark data reports an average of 50% of that second rate, and then our audience seeing that as well. So it seems like we're all having really consistent experiences. So interesting to kind of fact check that from the benchmark data.
That brings us to our final question before lunch. Does your organization provide compensation in addition to the regular call coverage per diem or the rate for the independent contractors providing care to indigent patients? So let me just explain what that means. Sometimes we see arrangements where all the physicians get the same rate per diem. So they're getting $1,000 a day. However, if they're seeing an uninsured or indigent patient in the emergency department, sometimes the health systems will guarantee up to a percentage of Medicaid in collections, or up to a percentage of Medicare in collections. So we've seen that. Typically, it's based on a percentage of Medicare. It's not as common. Out of 20 arrangements, maybe 2 have something like that I've seen, but it is something we've seen. Most often, it is a percentage of Medicare, although I have seen a percentage of Medicaid, especially for pediatric specialties. Yeah, this doesn't surprise me. There's That's not as prevalent as it was. It used to be much more common years ago.
And I think operationally, this probably makes for a cleaner arrangement. So not surprised and somewhat happy to see that no is the prevalent answer here.
Awesome. Well, that is our last slide, I believe, Eric, isn't it?
It is.
After this? All right. Well, we want to thank everyone for attending today. We're happy to answer any questions. You can reach out to Ericka or I. We're happy to have phone calls, answer emails. Call coverage is one of our favorite topics. As Ericka mentioned, we just wrote an article on call coverage qualms talking about that independent contractor and employed physician relationship and whether the per diems would be the same or not. We just kind of talked about some of the different facts and circumstances to consider. We're planning on writing a few other articles this year, kind of continuing that conversation on the various elements and different topics of call coverage. So we're happy to we'll share those as we post them on our website. And always happy to answer questions. Any closing thoughts from you, Ericka?
Yeah, I just appreciate everybody's time and participation. It's so interesting to see what our audience and what our clients are experiencing and kind of bump that up against Zach and I's experiences and bump that up against benchmark data. So really great to get real-time feedback. So appreciate everybody's participation today. And I'll pass it over to our moderator to close us out.
Thanks to our presenters, Zach and Ericka. Later today, you will receive an email with their contact information and a recording of the webinar. Also, all information on this and future episodes of PYA's Unscripted series is available on the Insights page of PYA's website, www.pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.